that is hosted by the Gastro Foundation in association with Project ECHO, University of New Mexico. These sessions are held weekly, and we have a HCC session approximately once a month. The chat will be open for questions. So please, if you have a question, just post it in the chat and we'll deal with it. Alternatively, we'll have time to break for questions and you can just raise your hand and we'll deal with it there then. So today we would like to thank Jackson Chipaila, who's going to give us a presentation on HPB surgery in Zambia. Jackson is the only fellowship-trained HPB surgeon in the entire country of Zambia, and I think his talk is going to show what some of the challenges are in dealing with or managing HPB problems in Zambia, and I think a lot of these problems are shared by many of us. We're then going to follow that with a panel discussion by Anasai Chihaka and from Zimbabwe, and Rashid Nashidingo from Namibia. And also we're going to focus on what treatments are that's going to specifically be with regards to hepatocellular carcinoma, what treatment options are available in those countries, and what's lacking, and perhaps we can think of some practical ways that we can improve things going forward. Jackson, do you want to start?
Thank you so much. Yep, I think I can start the presentation.
We're seeing that, Jackson.
Are you able to see my screen?
Yes, we can see it. Perfect.
Thank you so much for giving me this opportunity just to present on hepatobiliary services in Zambia and what have we been up to here in Zambia. So my name was already introduced. My name is Jackson Chipaila. I have no disclosure to make. Basically, the content of my presentation will include the introduction, the background. Then we will deal with the pancreas surgeries we've been able to do, the liver surgeries, the biliary surgeries, and of course, a SWOT analysis and a summary. At the end of my presentation, I'm very hopeful that I'll be able to highlight the disease burden of hepatobiliary pathologies within Zambia. Also give an overview on how we've been able to establish these services in our low resource setting, and also describe our current services we've been able to provide, and look at our outcomes, and of course, the challenges we've been able to face through this path. So Zambia is a landlocked country. It's surrounded by Angola, Zimbabwe, Namibia, Malawi, Tanzania, and of course Mozambique. The capital city of Zambia is Lusaka. Zambia has got a population of about 19 million people. If there's anything about Zambia, which I always want to bring out, what is good about Zambia is the fact that in Zambia, we boast of hosting one of the wonders of the world, which is the mighty Victoria Falls. I'm always joking with my colleagues from Zimbabwe that we're always fighting for this identity, who owns the Victoria Falls. Of course, the fact that the Zambezi River is in Zambia, I think Zambia owns the Victoria Falls. Like in any other country, our health system in Zambia is well structured. We've got different levels of healthcare. We've got the primary healthcare, secondary healthcare, and we've got the shared healthcare. And this is supported by a different hospital or health facilities. In the primary health care, this is supported by health posts and health centers. Then these are able to refer patients to a district hospital, and every district hospital is able to refer a patient either to a general hospital within its nearest proximity or to a tertiary hospital. So in Zambia, we have a well-established rural and referral health system. We have 6 tertiary hospitals. Of these, only one of those hospitals has got a hepatobiliary and a pancreatic surgical unit. This surgical unit is located at a hospital within this country called Levi Mwanawasa University Hospital, which is currently the only center and the national referral center for all complex hepatobiliary cases. This unit was established in 2021, and it is composed of 1 hepatobiliary surgeon and 2 general surgeons. And we are always supported by either trainee surgeons, anesthesiologists, theater nurses on a rotational basis. Currently in Zambia, we have no any ERCP or EUS services. In Zambia, like other countries, say Japan, I think also the US, endoscopic services are mainly provided by the gastroenterology physicians and not the surgeons. Of course, we've got a few surgeons who do endoscopy, but mainly is done by the gastroenterology physicians. Levi Mwanawasa University Hospital currently is the only hospital with a colonoscopy. Our unit, which is the hepatobiliary and pancreatic unit, it is well supported by the interventional radiologists. Of course, we are in our infancy. There are no liver transplant program currently in Zambia. We are well supported in terms of investigations caused by the National Health Insurance Scheme. This scheme is quite recent in Zambia. However, it has come very handy in the sense that it has given access to our patients to be able to do CT scan, MRCP, tumor markers, and histopathology, just to mention but a few. This is a picture just indicating our hospital, Levi Mwanawasa Hospital. This hospital is one of the biggest hospital, single standing biggest hospital in country currently. It has got a bed capacity of over 750 beds. And this is the hospital which currently is a national hub for all complex hepatobiliary cases in Zambia. It is situated in Lusaka, the capital city of Zambia, which has got a population of about 2 million people. The scope of the surgeries we've been able to perform since we got established in 2021 include pancreatic surgeries, liver surgeries, and biliary complex surgeries. Among these pancreatic surgeries, we've been able to do the classical WIPO, or the subtotal stomach preserving pancreatectomy, which as a unit, we've been able to adopt as our primary type of pancreatectomy. We've been able to do radical antegrade modular pancreaticosplenectomies for tumors of the body and tail of the pancreas. And we've been able to do these ramps, either ramps anterior and posterior, dependent on the indication. Liver surgeries, we've been able to do anatomical resections of the liver that include right, left hepatectomies, right trachenectomies, and lateral sectionectomies. And of course, we've been able to do non-anatomical resection. We've been able to do extended cholecystectomies with or without extrahepatic bile duct resection. And we've been able to do some laparoscopic deroofing of the liver. Of course, laparoscopic cholecystectomy is not among the cases we count in, because that is not only done by our unit, but also the other colleagues who are the general surgeons are able to handle that. Then we've been able to handle biliary complex surgeries. These include open extrahepatic bile duct exploration with our cholecystoscopy, and of course, repair some of the injuries post-surgeries of the biliary tree. According to the Zambia National Registry, Cancer Registry population-based data, you can actually be able to see that liver cancers are one of the common cancers in Zambia, which most of our patients present with at our cancer disease hospital. The prevalence per 1,000 population was reported at 3.1 for liver cancers. This is more than stomach, bone, vaginal malignancies. This simply indicates that indeed in country we have such a burden, and especially when you look at the patient-doctor ratio, this even magnifies the problem in country. When you look at the pancreas in terms of the data at our Zambia National Cancer Registry, we've got quite a number of cases which are reported. And remember, even our collection of our data might not be as accurate as it might be, because of not all patients have access to report themselves at our Cancer National Center to be entered. This simply means that the burden in country is more than what they will be able to pick statistically. When you look at the pancreatic surgeries we've been able to do, we've been able to do up to date 19 WIPOs. We've been able to do 5 anterior ramps and only 1 posterior ramps. What is of interest here is that if you look at the presentation of our cases, is that most of our patients were actually below 50 years, meaning that we have such a young population which are presenting with pancreatic pathologies. Out of these 19 cases which we did, when you look at the discharge status, is that we only lost 3 out of 19 patients in the first 3 months after the operation. The commonest cause of death in our patient was post-operative hemorrhage. One of our cases was that the first reason, the reason why the patient had post-operative hemorrhage, is because that we technically used the wrong staplers to anastomose our gastroduodenostomy. Instead of using our 3.8 millimeters length staples, we used our 4.8. We used our, instead of using our 4.8, we used our 3.8. So that itself is the reason why we had that hemorrhage in this patient. Then when you look at the pathology, most of these patients had the problem of the presentation was because of the tumors being located at the head of the pancreas. We had only 3 cases of tumors which were located within the biliary tree, and we had another 3 cases of tumors located in the duodenum. When coming into the patients with tumors located on the body and tail, the outcomes of this patient was good. We have not lost any patient from those patients we've operated with tumors on the body and tail. When you look at the average operating time, our average operating time as at now, it stands about 13 hours. I will give more detail why it is so. This is basically a much more detailed slide giving us more information on our first 10 cases we did. Something of note of these patients is that none of these patients is that only 1 out of 10 had a pre-operative pathology beforehand. That is tissue diagnosis. The rest of our patients never had any tissue diagnosis before our surgery, simply because currently in country, we do not have any EUS FNA. So therefore, only patients with tumors within the duodenum or anywhere across the duodenum that our GI physician can do the endoscopy and able to access the tumor. So the rest of our patients, we went in to operate on these patients with our radiological diagnosis. Therefore, radiological diagnosis has been key on our end to be able to go ahead and operate on our patients. The other thing of note is that we have patients we've taken in to operate with very high bilirubin levels. The reason is the same challenge. Currently in country, we do not have ERCP. We do not have ERCP where we would want to stent our patients, bring down the bilirubin, then proceed to operate on the patient. This has been key for all our patients. We have those with liver, for liver resection, if at all they are coming in with any form of elevated bilirubin. What has been helpful is also the fact that our selection of patients has been very key, that we've only operated on patients whose performance statuses has only been either a 0, a 1, a maximum of 2, and any other we do not, for the obvious reason that we want to have good outcomes in our patients. Much more detail on our cases is that when you look at our first patient, although we intended to have our first case with less complexity, unfortunately, when we went in intra-op in this patient, was that we had no option but to go in and do a superior mesenteric vein resection and primary anastomosis. When you look at the operating time, our operating time took us about just over 20 hours. 20 hours simply because this was the first time as a team we were having an experience to be able to do this procedure. Therefore, the team was also learning in. Besides that was the fact that this case was not only a Whipple, but it also included us having to do a superior mesenteric vein resection and primary anastomosis. When you look at our operating time, our operating time improved with time, with our lowest operating time of 8 hours. on our 6th patient. This was a tremendous improvement in terms of time of operating vis-a-vis also the outcome of our operation. When you look at the pathological diagnosis of this patient and the outcome of a patient, of course, we are not able to manage to achieve our intended R0 resection on every patient. However, as you can see, patient 1, patient 2, patient 3, 5, 6, and patient 10 were able to achieve an R0 resection, while these other remaining patients, 4 of them, we had an R1 resection, meaning that there was positivity in terms of malignancy at our cut end. This is another challenge which we have in country, that we are not able to do fresh frozen section immediately. This is something we want to do before we begin our anastomosis. We make sure that our cut ends are negative of any form of malignancy. However, so far we have been able to achieve acceptable results. The fact that we've been able to have R0 resection in our patient and also improved in terms of our operating time. PDAC was the commonest indication for our cases. As you can see, that most of our cases here had a pancreatic duct adenocarcinoma. In terms of our complication, postoperative pancreatic fistula was one of our complications. However, our most notorious complication out of these cases was postoperative pancreatic pancreaticogelectomy hemorrhage. This was the reason for the mortality in our patients. This is our surgical view of our first patient we operated. As you can see on our image A, you can see the anastomotic site of the superior mesenteric vein being joined in by the splenic vein to form the portal vein. This is our cut end of our pancreas. Then this is our superior mesenteric artery, was cognized and tagged. Then this is our middle colic artery. As you can see, even the vessel loops, I just have to use the ends of gloves to create them, to use them as my vessel loops. Then image B is the picture of our specimen after we are done with our resection of our pathology. The cut end of the common hepatic duct, as you can see, the jejunum there, the stomach, and the gallbladder there. And this is the head of the pancreas. Detail of our other patients. These are patients who underwent ramps. Like I indicated, this is the total number of our patients with ramps. All of these patients have done well. We have not recorded any mortality in our patients. And the commonest indication for these patients has been SPEN. Acidopapillary epithelial neoplasm has been the commonest indication why we have had these cases. And the presentation of these patients, all these patients have been young patients, very, very young patients, in their 20s, female. The commonest complication which has come out of this is postoperative pancreatic fistula, which has easily been managed by just keeping our drain in situ a little bit longer than usual until to dryness, then we'll be able to remove. Our operating time has ranged between 10 hours to 4 hours. And the 10 hours was the fact that when we started to operate when we started as a unit, we were deliberate. We started with first ramps before we attempted to do a WIPO. So the first patient with 10 hours was our first patient we were able to showcase pancreatic surgery. However, as you can see, the time range is about 4 to 5 hours currently in terms of ramps. This is a specimen. This sorry, the A indicates showing us the surgical view after resection of our tumor. As you can see, this is the cut end of our pancreas. What you're seeing here is nothing but just some surgicel which was put on the cut end. Then this is a common presentation of our cases. Very huge tumors. As you can see, this tumor is about 20 centimeter. As you can see, 30 to 10. This is the size of the tumor. This is the cut end of the normal pancreas. So this is the common presentation of our patient, late presentation, presenting with very, very huge tumors. But as a team, we've been able to offer them this service, and they have all done well. We've been happy with the outcome. So when coming into cases to do with liver surgeries, amongst the liver surgeries, we've been able to do 6 anatomical resection, 4 non-anatomical, and 3 others. If you compare the numbers, you actually notice that our cases with liver surgeries are less than pancreatic surgeries. Like, we've been doing much more pancreatic surgeries than liver surgery for obvious reasons. When you look at the data showing us in terms of the disease burden and presentation at our National Cancer Registry, it shows that we have more patients with liver pathologies than pancreatic pathologies. Yet, when coming in to operate, it has been the other way around, simply because of the patient-led presentation. We have got very few patients who are able to salvage. So amongst the patients who are able to present to us, who are able to operate, this is the number we have. This simply indicates that we have so many patients who present to us very, very late, such that even at the point of presenting to us, surgical intervention cannot be done on them. Like it is in the pancreatic pathologies, most patients we operate on them are very young. Age is less than, when you look at the age, most of our patients were less than 50 years old. Less than 50 years old. When you look at the sex ratio between male and female, almost the same. We've got almost the same. Then in this what we put in the non-anatomical resection, we have patients, we lost 2 patients. These patients are patients we had offered an extended cholecystectomy because of gallbladder malignancy. So looking at the poor outcome we've had with our patients with gallbladder malignancy, as a team, we have almost put a halt to any surgery to do with gallbladder, not until we are certain our surgery will be able to bring in a better outcome in our patients. The aggressiveness of gallbladder malignancy has made us hold onto gallbladder malignancy, because all our patients we tried to offer any form of surgeries, our outcomes have been poor. So we've had 2 patients we've lost in from after our resection, our extended cholecystectomy, which included resecting the gallbladder bed. However, the other patients we resected, we have had acceptable good outcomes. All our patients are doing well. The commonest benign indication has been hemangioma. Most of our patients are becoming in hemangioma. And of course, we've had patients, yet we have had so many patients with HCC. We've been able up to date only operate on 3 patients as an indication for our operation, as an indication for the operation. Our commonest complication has been bowel leak. We've had 2 patients who we've operated in and bowel leak. This bowel leak we've been able to manage it easily, in the sense that we've been able to just keep our drains in situ a little bit longer than patients have been able to recover from it. Then this is cases of the complex hepatobiliary cases. When you look at the complex hepatobiliary cases, these are cases which some of them have been corrective surgeries. These are cases of patients, probably our colleagues have attempted to do, have gone ahead to do a cholecystectomy. However, there was some biliary injury and patient has been referred to us. That is one of the indications we've had where we have had to go in, do extrahepatic bowel duct exploration, and go in and do a hepatococcygeostomy. If it's not a hepatococcygeostomy, we've had patients where we have to do a hyalogenital anastomosis because this injury was very, very high. The others, these are cases which we have had to do extrahepatic bowel duct exploration using our cholecystoscopy. Like I indicated, currently in country, we don't have any ERCP. So patients with cholecystectomy lithiasis, they'll come in through us, then we shall do an open extrahepatic bowel duct exploration with exploring using cholecystoscopy, where we've been able to go in and extract these stones. We have had cases if you've seen, which I've highlighted down here, is that we've had lost one patient. This is a patient who cholecystectomy was done, and a cholecystectomy was done, and there was a very high injury of the hepatic duct. The unfortunate thing was that there was a delayed referral of that patient between then and us. By the time we were trying to attempt to salvage this patient, the whole remaining stump of the hepatic duct had completely contracted into the liver, such that we had so much difficulties to finding it. We tried to push in a PTPD tube in, however, patient could not make it. This is a benign lesion. Unfortunately, it led into a death. This is how sometimes our cases with hepatobiliary could be that complex. This is the reason where ERCP is possible. It comes in handy to be able to avoid unnecessary surgery in these patients. And the other thing of note is that all these cases we were handling which we are calling in the complex, which we are going in to re-explore and do these hepatico-entero anastomosis. If you look at all these cases were all benign indications, were all benign lesions. None of them is as a result of a malignancy. Most of them actually, sorry. Then we also decided to do a SWOT analysis. Our strength as a team is that we currently are a young team, meaning that we are eager to learn, we are eager to explore, we are eager to want to do more. And of course, is that we have government support, and that we have currently and been deliberate to centralize this practice. Centralizing this practice has been helpful in the sense that it has been able to easily help us mobilize resources to one place which we can use them on our patients. What is our weakness? Our weakness is is that we are lacking experience. We are not experienced. So that itself is our weakness. then as indicated earlier, we have very limited skilled human resource. The day the hepatobiliary surgeon gets sick, it means that the unit is disbanded. When coming into diagnostic and therapeutic equipment, we are lacking. What are the opportunities out of this week? The opportunities is that we've been able to pioneer hepatobiliary services in country. We have an opportunity to even go ahead and begin transplant services. So much opportunity in research and collaborations. And of course, the threat is the fact that, like any other part of the world, is the aspect of brain drain. Brain drain can be brain drain in country where you have these surgeons leave the public sector, go to a private sector. Burnout. The team is very small against so much work. The fear is burnout. People might get tired. And sometimes we lack the support from various stakeholders. There are times you expect that these people who are your seniors, who were your teachers, would be the ones to give you the support, but sometimes you get surprised that that's why you receive the least support. In summary, in Zambia, it is clear that we have quite a large burden of hepatobiliary and pancreatic pathologies, as you could see with the statistics. And especially when you look at the patient-surgeon ratio, it's overwhelming. However, we had to start from somewhere. Even with the small number of surgeons, with this small team, as a team, we decided, let's start. And this is how we've been able to begin to do something about it. And we are happy that from what we've been able to do, our surgical outcomes are acceptable. Yet we know very well that there is much more to do. It is for this reason we are on a daily basis seeking for our mentors, support, sponsors to enable us have our other colleagues go to train in, and also us who are already started the practice be supported. Thank you so much.
Thanks very much, Jackson. I think it's fantastic what you've taken on, and I think it's great that you've pioneering HPB surgery in Zambia. I also just want to take the opportunity to welcome Peter Kingham, who's the chairman of the iHPB Outreach Committee, who's joined the meeting. Welcome, Peter. Just a few questions that have popped up in the chat. One of them was essentially Akwi Asabang. What is the comparison prior to you setting up the HPB unit? Was there any of this type of surgery being done in Zambia at all? Was there anyone who was doing this? And in the past, has any of this surgery been done in Zambia?
Thank you so much for that question. I'm not aware of any successful WIPOs being done in country before then. Yeah, I'm not aware of any successful WIPOs done within then. Before, I think the time I was in my undergraduate training, I could hear This is not recorded data, but I could hear from from seniors indicating that some time back people attempted to operate, but patients did not even make it over 12 hours from the time they operated. Therefore, they do not encourage anybody to attempt. I think for me, this is the reason I was pushed within to want to go and further up my study in that, because all cases during my training as an undergraduate, even my postgraduate training, all patients we had who had pancreatic pathologies, almost nothing was done apart from bypass surgery. Nothing definitive surgery for a patient with pancreatic tumor.
You mentioned that you don't have ERCP or EUS available, and that you also mentioned that you have interventional radiology. Are you able to do PTCs? And just another quick on that, are there plans to try and establish an ERCP service? And is there any way like that maybe in places where ERCP is available in Southern Africa that we could maybe assist in setting up an ERCP service in Zambia?
Thank you so much. So I'll start in with the aspect of interventional radiologists and able to put up a PTB tube. Yes, interventional radiologists we have. We have one of my colleagues who actually got trained in South Africa, Dr. Mike Chisha, who has been very helpful and supportive. So what has been there is the aspect of that we are but limited in terms of our picture catheters in. So therefore, we've been very selective on which patients we should be able to use the few resource against which kind of patients. So in terms of inserting in of the PTBT tubes, our interventional radiologists are able to. Currently, we've also got one at my hospital, the same Levi Mwanawasa, Dr. Ntien, who's the head of the Department of Radiology, has come in very handy and is able to deal with those cases in. When coming to ERCP, I think this is something we are working in the background. This is something even Dr. Akwi Asobang has been very passionate about in terms of wanting to find a way we should be able to set up that. At my hospital, where I am in, like I indicated earlier, the endoscopic services are mainly handled in by the physicians. I have been in touch with my colleagues who are leading in endoscopy, that team we have to progress from our basic endoscopy to advanced endoscopy. Well, that includes ERCP. So if there's any center in country willingly to undertake that progress, is our center. So how to do it is one, one is the aspect of the leading team, given that exposure from anywhere else to go and do that training, or incoming faculty to be able to come in country to be able to give us that support.
Okay, so it's an interesting thing that we must think about how we're going to deal with that. I think in the interest of time, we're going to move on. And then, so we're going to now focus on HCC, and Onasai Chihaka is just going to give a brief summary of what HCC services are available in Zimbabwe. Onasai, I think you might be muted. Still can't hear you, Onasai.
Okay. Sorry. Good evening, everyone. I hope you can hear me. And yes. I hope you can see my screen. Right. Yes. We thank you very much for the opportunity to share our experience in Zimbabwe in terms of hepatocellular carcinoma. So that's sort of the outline of my presentation. I'm just going to give you a case that shows the kind of or treatment option we do have in the country. And then I'll just give you a brief, very brief summary of our case series in HCC. Right. So the case that I'm going to share with you is a Mr. EM, a 52-year-old farmer. who presented to us with a vague right upper quadrant pain for several months. He didn't have any weight loss or any other constitutional symptoms. He had a very good performance score when we saw him. On examination, he pretty much unremarkable. But of note, his alpha-fetoprotein was quite elevated. His hepatitis screen showed some previous exposure to hepatitis B. So we did have a CT scan. So I just had to put a few cuts here of the CT scan that we had. But the report was that he had a shrunken liver, and he had this lesion in segment 5-6, which showed some rapid washout in keeping with an HCC. So he was a very successful white farmer and quite resourced in terms of financing his treatment, which is usually an issue in our setting. So he was prepared to go all the way. So we had this treatment option that we discussed with him, right hepatectomy, but we were concerned about adequacy of his liver remnant. We were looking at the cirrhosis, despite him being a child PUA. Microwave ablation, we thought maybe the tumor was too big for that. TACE, either as a palliation or as bridging therapy. Selective internal radiation therapy, which we don't have in our setting, but because he said whatever is available anyway, I would be happy to go. It's another option we discussed, including liver transplant. So after having all this discussion, our patient disappeared and then reappeared several months later. So during his absence, he had gone to India, where he got set in August of 2019, and then came back with a new CT scan that showed quite significant tumor shrinkage. There was some hypertrophy of the left lobe, and his liver function was still preserved. His child Q was still A, and he was still of a very good performance score. So at this point, we thought maybe we should consider giving him a curative resection. And in December, that's about 8 months after we saw him first, in the interim, he had gotten his set. We did a hepatectomy. Clearly, his liver was quite cirrhotic, but his left lobe had quite petrified well. Our perioperative period was uneventful, and 3-month follow-up CT scan and a clinical follow-up and CT scan. His alpha-fetoprotein had normalized or was just slightly above normal according to our laboratories. His LFTs were normal, and his liver looked quite clear with good hypertrophy. The liver function was normal. So we were quite happy then. This was 3 months post-surgery. Then we scheduled him for a 6-month review, which was essentially okay. His alpha-fetoprotein was fine. Ultrasound scan didn't show anything new. But in October of 2020, we noted a rise in alpha-fetoprotein, and this prompted us to do a CT scan. And on this CT scan, we saw that new lesion that appeared in segment 2 there. And we are lucky we do have an interventional radiologist who offers microwave ablation. So we send this patient to for interventional microwave ablation, which was done in September of 2020. And that was the post-operative, post-procedure CT scan. The alpha-fetoprotein remained high, and there was concern of incomplete ablation. And the discussion was to do reablation, but the patient opted to try again to disappear to India for a transplant. Unfortunately, when he got to India, he had taken his siblings to be live donors for him. He got COVID, but that was at the height of COVID, and he had to be admitted in hospital for a couple of months, for a full month in ICU. And eventually, when he got his CT scan wake-up, they noted some pulmonary lesions, which were biopsied and confirmed metastatic HCC. And so transplant was abandoned, and it came back to us for palliative treatment. So the following year, July 2021, we saw him this time around. Unfortunately, he had quite significant disease progression, liver decompensation, came in with ascites, and also had new multiple lung and liver lesions, and was initially put on palliative sorafenib in July of 2021. And 6 months later, that's when he succumbed to his disease. But that was almost close to 4 years from the 3 years from the time we started seeing him. Yeah, so this case was just trying to illustrate sort of the options that we have, and this patient got almost all of the options that we can do. In terms of the option that we have here, we do have curative intended options, resection, liver resections. We have been able to do them since 2018 when I came back into the country. We do have an interventional radiology unit which provides microwave ablation, and the same unit also does transarterial chemoembolization for us. The resection is available both in the private sector and also in the state hospitals, but microwave ablation and TACE is only available in the private. It's not yet available in the state. So for the majority of our population, this is probably not available because of the financial constraints, but it's an option that is available for us. Then when it comes to resections for HCCs, over the last year or since 2022 to date, we have done 18 liver resections. 10 of these were actually for HCC. It may sound like a big number comparing to what Jackson had presented, but these 10 would probably represent 1% of all the HCCs that we see, because majority of them, by the time they come to us, they are usually for best supportive care at best. So of the 10 that we did, 2 of them were actually in normal liver with no hepatitis, non-cirrhotic livers, no hepatitis. 3 of them were actually hepatitis B positive, but with no cirrhosis. Then 4 had hepatitis B with cirrhosis, but with a preserved Child-Pugh score. And 1 of them had cirrhosis, but we haven't been able to establish the cause of the cirrhosis at the moment. But these are these 10 cases that we have done over the last year and a half. In terms of our outcomes, we haven't had any mortalities. Majority of our cases that we have operated were actually young patients who were under the age of 50. Maybe because of selection bias, we've been trying to do the ones that we felt we could assist. Maybe that has contributed to our low mortality, zero mortality. One of our patients that we did with liver cirrhosis in the background of hepatitis developed a transient liver failure. I think it developed hepatic ischemia during surgery, because we did have a prolonged time where we needed to do a Pringle on him. And he also is the same patient who developed an acute kidney injury, but luckily for him, all of this resolved within weeks. Of all the patients that we have done, 3 of them have recurred within a year. One of them was the one non-cirrhotic, non-hepatitis B patient who had fibrolamellar, a 19-year-old female patient with fibrolamellar HCC. This one came back within 6 months with multiple liver lesions and succumbed, I think, 8 months down the line. The other patient had an HCC, but of note is that his pre-operative alpha-fetoprotein was beyond 20,000. I think that may also have contributed. He may have more disease burden than we had seen on CT scan. And the third patient is the patient that I had presented here who had a recurrence. We have lost 2 of our patients to follow up, so we have no idea what has happened to them. But 5 of the patients that we are following up are still disease-free currently. But it's only a few years. We still need to follow them up long term. Microablation is also available, but only in private. from the patient that came through our service, we referred 3 elderly ladies with very small HCCs for ablation because we felt they were not quite fit for surgery, and they've done very well so far. But our interventional radiologist also receives direct referrals from fellow clinicians, and he does quite a few of these microwave ablations, but I don't have the statistics of how many he has done, but he does quite a few. And he is the same person who also does transarterial chemoembolization. Yeah, the only challenge with this service is that it's only at the moment available in the private sector. So it's only for the privileged few that can access this service. So in summary, our treatment options that we have in the country is liver resections, which I think we are doing reasonably well, microwave ablation, transarterial chemoembolization, and we also do have sorafenib for palliative treatments. And we do have a good island hospice service that also tends to help with best supportive care for those patients who are within our major cities where that island hospice service is available. So in summary, this is what we do have in Zimbabwe, and I would want to say thank you very much for the opportunity to share our experience.
Thanks very much, Onosai. I think the patient was well managed. It's a little bit tragic that the patient has to go all the way to India to get care, and you feel that we should be able to do that locally. I see Ed has his hand raised.
Just unmute. Yeah, thank you, Mark. Jackson and Onosai, thank you very much for very frank presentations about the situation where you are. It's really admirable that you manage to do what you do with a few resources that you have. I just had one comment actually, and we've got the same problem when it comes to the estimations of the incidence of HCC. Even in our cancer registries in South Africa, it's based on histology, and we know that the histology is performed in the minority of patients. It's imaging-based diagnoses. So I think there's a massive underestimation of the actual incidence in the many countries. And if you see many of the statistics, it's actually statistics that are based on a guesstimate of what is happening in the rest of the continent. I just wonder if there are any questions. If not, I would just give Peter Kingham the word, because he put in the chat as well that there is an initiative from the IHPBA at the moment to establish relationships in between units in low and middle income countries that maybe face challenges that one doesn't face in the rest of the world, and units or established unit in high income countries. Peter, so I don't know if you just want to speak to that for a few moments.
Yeah, thanks Ed and Mark for inviting me. Great to hear both presentations. And a very well-managed case of HCC, where unfortunately, no matter where you are in the world, many patients will progress like this, and really it ends up being palliative treatments for many patients with HCC. So sort of screams out to everywhere we are to try and find patients with earlier stage disease to try and minimize this. But this is the unfortunate reality of HCC for all of us. But very, very well managed. I did post in the chat the link to the IHPBA program. So the IHPBA, International Hepatopancreatobiliary Association, is the umbrella organization of the 3 regional associations. There's one in the Americas, there's one in Europe and Africa, and there's one in Asia. The biannual meeting is actually in Cape Town, that Ed is one of the leaders of in 2024. And leading up to this, we've been tasked with trying to create a way. There's so much interest in growing HPB surgery in low middle income countries, and also and collaborating in high income countries. And myself, I've been collaborating with Isaac Alatishe, who I know some of you know, in Nigeria for many years. And Isaac is an example of another homegrown HPB unit that has really grown into a high volume center. So you can click on the link to read more about it. It says you had to send the information by the end of July, but if you're interested, please click on the link. I'll put my email in as well. If you have a problem, just email me directly. But we would love to have many of you on this call involved in this. And also, this is demonstrating to the leadership of these societies how much interest there is. I can tell you we've already had about 80 different people express interest from around the world, which is much higher than we expected. So I think there's really a lot of interest in helping these collaborations and fostering them along. Thank you for having me today.
Thanks, Peter. Also, I just had a message from Chris Casanides. He's the chairperson of the Gastroenterology and Hepatology Association of Sub-Saharan Africa. That said that they would also be very happy to engage, especially in the training of ERCP operators, endoscopists, Jackson, that you may will need some help with. Chris, I don't know if you want to say a few words on that. I think you're muted, Chris.
Exactly that. For someone like Jackson, who's made such an important start, it behoves us to just focus and offer him this focused need of ERCP. So whether he's able to come or send someone to Kritiskir, we would certainly assist with the costs. And there are so many people who could visit him once the initial in the initial start has begun. So Jackson, you have my email, or you have Mark and Ed's email. You're free to contact me for some support.
Thank you.
Thanks very much, Chris. Okay, I think I'd like to really thank everyone. I think it provides some food for thought, and I think we really need to try and think of ways that we can help each other and try and make a difference and improve HPB services. I'd like to thank everyone for joining the meeting. And I'd like to thank the HECO team and the HECO India team. Recordings of this will be available on the Gastro Foundation website. Thank you to all the presenters, the sponsors. And next week's topic is patient blood management. Thanks. Thank you, everyone.
Mark,
sorry,
Mark, just
yes.
Yeah, know that Rashid Nashidengu had to present as well, but we were running out of time, so we'll have his presentation at our next meeting.
Yeah. Thanks. Thanks, everyone.
Thanks, everybody.
Thank you, Prof.
Thank you.